Well, good morning to all of you. Thank you very much for coming to the Woodrow Wilson International Center for Scholars. And it's my pleasure to welcome you to the Directors Forum, co-sponsored by the Global Health Initiative on Universal Health Care Coverage in the United States. Let me thank Jeff DeBalco. Jeff, are you here? Let's see, he'll be here, I'm sure, shortly. He's done excellent work, along with Gib, in putting this program together and to organize the event. A record number of Americans have inadequate or no health care coverage. Health care costs are rising relentlessly. Reforming our health care system is surely one of the dominant issues in our public discourse, demanding informed and open dialogue of the sort that we will have today. Woodrow Wilson, in my employment contract, I get a bonus every time I mention Woodrow Wilson, so I'll quote him, and he said that, he's a very intellectually strong man to the point of arrogance, but he did say on one occasion that I use all the brains I have and all I can borrow. And that's an important insight because no one of us, of course, are smart enough to solve these problems that we are talking about today. It's my pleasure to introduce Dr. Robin Cook. He's a member of the Woodrow Wilson International Center Board of Trustees. For the last 2 years, he has been very helpful to the board on a variety of matters, but has given us guidance and direction on public health and other matters. Robin's really a Renaissance man, soldier, physician, man of letters, athlete, entrepreneur, and he even ran a restaurant at one point. I don't know whether you still do or not,
no,
Robin.
Don't advise it either.
But he is best known for sure as a novelist and really the founding father of the medical thriller genre. He has published, I think, 26 books, including Coma, Outbreak, and the most recent book, Critical. His work has been translated into 40 languages, sold over 100 million copies. He's used literature to address some of the most challenging scientific, medical, and ethical issues of our time, including stem cell research, cloning the human genome, and bioterrorism. Veteran of the United States Navy, he achieved the rank of lieutenant commander, did his undergraduate work at Wesleyan College in Connecticut, medical school at Columbia, and he's also a graduate of Harvard's Kennedy School of Government. He's married, and he and his wife have one son. Robin, we're delighted to have you presiding today, and I'll turn the program over to you.
I'm glad this isn't a conference on the environment. It takes a lot of trees to make that many books. Well, we have a terrific group here to talk to you about how to change healthcare. Of course, I don't know whether anyone's going to know whether we're going to change healthcare because this has been a problem for some time. When I thought about what my role was going to be here, I felt a little bit like one of Elizabeth Taylor's latter husbands. I know sort of what's expected of me, but I don't know how to make it really interesting. And I thought, one of the things that's bothered me about healthcare, in terms of healthcare change, is that the public has kind of a strange ambivalence about it. Maybe they're a little excited about it, they're not excited about it. It's hard to get them to really talk too much. And I remember asking a lawyer friend of mine, who's very interested in policy, I said, exactly, is this ignorance or apathy? And he said, I don't know, and I don't care. It's really so apparent we have to change healthcare. And why we haven't been able to do it is, to me, it's kind of a mystery. I'm kind of a doer guy, want to get things done. And in this country, we've tried to change healthcare, I think, about 4 times. The first time was back at the turn of the last century. The people called the progressives really wanted to change health care. Country seemed to be behind it. But as they tried to present their idea, the opposition started to grow. And the opposition was particularly, they said, the idea of universal health care, it's this Prussian conspiracy, this right-wing Prussian conspiracy. Bismarck was the one that was really doing it in Germany at the time. And I find that kind of interesting because one of the other times where there was a big movement to get universal health care was in the Truman administration. But the opposition there said it was a left-wing conspiracy, and it was communistic and socialistic. So it's kind of interesting that we've been, the concepts get blamed to being on both sides. And what I get from that is that it's really an emotional issue. And whatever they can find, because even today, I was watching television not too long ago when President Bush was talking about the child bill, and he said it was just a step in the direction of socialized medicine. So they're still using it. I'm surprised. Maybe we should have gone back to the other one, alternate from being right problem and a left problem, whatever. There's no doubt that we should change it. I mean, there's so many things wrong, and we call it a healthcare system. It's not a system. It looks like one of our old hospitals. I remember particularly I did my fourth year medical rotation in Bellevue Hospital, which had been built over the years, and it's just this weird conglomeration of buildings, no relation to any, it was no rational idea or why this building was there or whatever. It just got built over the years. And that's sort of similar to our health system. It's extremely expensive. It's more expensive, as I think you all know. I don't want to repeat these things. You've probably read about them, but we pay like double than the next country in terms of the cost of medical care. And everyone sort of says, well, yeah, but we have the best in the world. In fact, Giuliani just said that not too long ago. I guess he hasn't been in the emergency room lately to say that this is the best medical care. And in fact, most of the parameters that we use today to measure the overall effect of health care in various and sundry countries, we're not number one. I don't know if we're number one in any of the parameters. And in fact, it's very sobering. The World Health Organization ranked, I think it was 191 countries, and we were somewhere around 37th or something like that. And then if you take almost any individual parameter for health care, a lot of that, of course, is because of the fact that we have 50 million people that don't have health insurance. And so President Bush said that, well, they still can get health care by going to the emergency room. But I don't know if anybody here has been in the emergency room lately, but the emergency rooms have certainly gone downhill since I spent a lot of time in emergency rooms when I was as a surgical resident, and then also while I was an ophthalmology resident, I moonlighted in emergency rooms, and things have really gone downhill. And I can say that with great. I actually had to be in an emergency room not too long ago myself in my own hospital, and the problem that I came in for cured itself while I was waiting. This is my own hospital, and I tried, tell people, hey, Dr. Cook. And you should see the way the nurses acted toward me. I mean, Dr. Cook, they thought maybe I was, ranting or raging or something of that sort. Now, I want to tell you a very, part of the problem of healthcare when you get in this kind of a circumstance, it always seems so abstract. So if you bear with me for just a minute, I want to tell a very quick story, a real story, and why it affected me and why I feel so strongly about how I do today about various and sundry medical ethical issues. And it was when I was a resident in ophthalmology, I had a patient came in that all residents just drool over. This was a patient that had bilateral cataracts, not just one, two. So residents, who were very competitive about doing as many as possible and finding out how many everybody else did. So I had this patient, and I explained to her the whole situation. She couldn't even count fingers, and she'd been that way for like 10 or 15 years. And I told her that she couldn't see very well, and she denied it. But I was able to talk her into having an operation. And so I took out one of her cataracts, and this was back before we put lenses back in. So I took out one. And then you wait a day or so, make sure that nothing untoward is going to happen. I didn't even put any correction on her because now she could actually count fingers, she could see light, and much more than she could before. Now I have to say we were in a new hospital at this point, and the examination room was 12 feet square. And this was done by an architect who should have known that they were building an eye hospital, because you have to have a 10-foot long room, a 20-foot long room in order to test vision, right? Everybody knows that, I think. They had a 12-foot square room. So I said, oh my God, the building's already built. You can't, break down walls and stuff. So he said, well, what we should do is put like a barber chair and a mirror and the eye chart and have them, look at the mirror and see the eye chart in the back and just calculate it out so that it's 20. Now, I took the other cataract out, and then I was actually had a junior resident with me, and I was explaining all the things that we were doing, and I checked to see what her prescription would be. I put them in the trial frames, and I'm talking to the other resident. I'm not paying any attention to her, which is not good. And I put the trial frames on. Now, this woman had been essentially blind for like 15, 20 years, and she was suddenly subjected to seeing about 20/30 in both eyes. And then I was rummaging in the desk to get the occluder so that I could test her vision. She, meanwhile, looked at the eye chart and grabbed my arm, and she said, doctor, something terrible has happened. And I spun around, and of course, at that point, you look at the eyes, you want to see if anything's coming out. No, you made a mistake then. Anyway, I said, well, what's the matter? And she said, well, when you took my eyes out, I think you put them in backwards. And what it was she was looking directly at the eye chart. I hadn't given her a spin yet. And the eye chart was to be looked at in the mirror. So she thought that I had taken this eye and put it in this eye. So the E's, instead of being this way. Oh, that's all right. And I said, oh, well, and I explained to her. But I thought about that issue a lot. And it just shows that there's such a gap between what patients know and what doctors know. They even speak a different language, and the pace of the science. I mean, it's even true now that doctors in this specialty hardly have any idea about what they're doing in that specialty. And what is that doing? Well, what it does is it empowers physicians in a way that's really unfair, because the whole concept of informed consent is you have to discuss it and make sure. I mean, I thought she understood what we were doing, but she actually literally thought that to do eye surgery, you'd take the eye out, and you do whatever you're going to do. And I guess it was one of like those old-fashioned radio tubes with all the things in the back, and you put it in there and you put the eye back in. Why I say this is because we have a terrible problem with cost. It's one of the biggest problems, not only in healthcare, but we have a terrible problem with cost of healthcare. One of the reasons that we have this cost is because we have a very strange system that doctors are paid according to how much mayhem they cause. In other words, the bigger the operation, the more whatever you do, the more blood loss, the higher they get paid. Now, what does that do? We have a system of reimbursement that reimburses very heavily in terms of procedures. The amount of money that is actually lost in this very irrational system is enormous. Now, some people might say, well, doctors are very ethical. Well, the problem is that they're ethical, but they're also self-interested. This is just human. And there's been enormous amounts of studies. And one of them just recently, this year, showed that if you put a heart hospital in a city that already has heart capability in their general hospital, that the heart hospital doubles the incidence of every one of the procedures that are done. This is an enormous cost, and also, unfortunately, even more unfortunate, an enormous loss of both a life or problems with, because a lot of these invasive procedures are not benign. I just bring that up just as a way of making people realize what we're going to hear from these gentlemen about how can we change healthcare it's about patients ultimately. It's not some sort of intellectual kind of argument it's about people. This medicine is where our public intervenes or comes up against science. It's essentially the only place. And so with that small introduction, I'd like to introduce the first speaker. We didn't really know exactly how we should do this, but we thought that that it might be best to start out with, and I'm not going to say what I think, because I want these guys to make their points. And I want them to respond to each other a little bit. My feeling is that this should be kind of a dialogue. We will entertain some questions, but I'd also like to encourage them to comment on each other's. Not smackdown, we're not, but in some really kind of fun way to get everybody to start thinking, because this is a really terribly important. You see the presidential candidates are now starting to talk about health care, but this has happened 4 times in the past where there's been a flurry of activity and thoughts, and the general public seems to be very much behind it, and then nothing happens. We're in a worse state now, 14 years after the original Clinton attempt at changing health care, and things are much, much worse. And so something has to be done. I was kind of hoping that business would suddenly become so strapped that it would be kind of an association with business and academic medical centers and the general public that could actually force a change so that something really, really would happen. So if I can ask the individual who is going to be talking about, this is James, and he is going to be talking about the way to change it by changing everything. Is that a fair way? All right. Thank you.
Great. Thank you. I'm Jim Morone from Brown University. And I play the role today of the ghost of Christmas yet to come. These guys don't solve the problem. Single payer is always out there. So I've been tasked with making the case for the single payer health insurance system. Let me start with the problems of our system. Robin's already laid them out a little bit. Let me just embellish on that for a moment. The intuition, the enthusiasm for single payer developed in about the early 70s because of, I was told not to bring PowerPoint, but let's imagine a PowerPoint. Slide number 1, please. In slide number 1, you see the comparison between the Canadian and the American healthcare systems in terms of costs. And you'll note that the lines cross, percentage of costs in healthcare as percentage of GDP. You'll see the lines cross 7 times between World War II and 1971. And in 71, Canada goes to their Medicare. Slide number 2. Wow, look at that. Case made. Canada, we go north, and Canada remains with bounces roughly flat. We are now 5% GDP, higher than Canada, 5 cents of every dollar more on health care. When people began to see those numbers, they began to say, well, they've got something we don't have. Maybe we ought to be thinking about that. The first problem of our healthcare system, clearly costs. A healthcare expert is a person with lots of synonyms for going up. And the striking thing is how our costs stand out. If you look across other countries, say for the last 5 years. Let's do another slide. There. Japan, last 5 years, 0. They're at 8% of GDP. That's where they were 5 years ago. Germany, rise, percentage of GDP, 0. Britain, the rise is 0.7 of 1%. Tony Blair, they say in England, is spending like a drunken sailor on their healthcare system. All the way up to 8.3. The British are going wild. The United States, same period, 2.1% of GDP. You think the Bush administration is about military? No. During the Bush administration, we've transferred 2 cents on every dollar. During the Bush administration, 2 cents of every dollar has been transferred over to the healthcare system with 1/10 left over. The point, 2 punchlines about this. First, That's an unstable system. We're not going to be able to continue transferring money into the healthcare system forever. And until we solve that problem, there's an instability built into the system. Where that instability ends, who knows? Uwe Reinhardt, the funny economist from Princeton, likes to imagine what it's going to be like when we're 100% healthcare, coast to coast, nothing else in an American economy. It probably won't get to that. But he's been started speculating about when that year is. I think it's a couple of years after the polar ice caps melt. Now, if we've got an unstable system, we also have lots of examples around the world about other nations that actually manage to control their healthcare systems as a part of their economy. And the principle that lies under most of those systems, the principle that lies under it, is a single-payer theory, at least. That is, that a monopsony buyer sets the price for everyone. There are some exceptions, but precious few. We're the outlier both in rising costs and in the way we set our healthcare prices. First problem, cost. Second problem, I'll be through my problems and to my solutions in just a minute, the lack of insurance. Well, you know about that. We're gathering somewhere between 750,000 and 1 million extra uninsured people every year. And it's not just the uninsured people, hard as that is. If you live in a small town, I live in a town in New Hampshire so that I can vote in the New Hampshire primary. I'll be selecting your next presidential candidate. You constantly run into these little cookie jars everywhere where people are trying to raise enough money to get some kid treatment that they can't afford themselves. It's a pathetic thing. Every time I buy the New York Times on Sunday at the general store, I'm also putting a few bucks in the cookie jar. And the kid inevitably dies and we figure out where we're going to donate the money to. It's a sad thing, all these people without health insurance. But what's worse is the patchy health insurance that people with insurance have. My favorite example of this comes from Judy Lave, an economist at University of Pittsburgh. She decided she was going to Europe, and though she's heard things about good European healthcare systems, she didn't trust the lefties, and so she bought her good old American health insurance to take her family abroad with. When the insurance policy came back, a funny thing happened. Husband, Judy, older son, no problem. Younger son was insured for everything but the right leg. The right leg was a pre-existing condition. She scratched her head. What? Her 8-year-old son had a pre-existing, and then she sort of worked it out and figured out that he had fallen, and rather badly, 4 years earlier, and had an x-ray taken of that leg. That was somewhere in the system, somewhere in the files, and the insurance company didn't want to pay for that right leg. It's a kind of emblem of the craziness that our private health insurance has gotten into. Costs, lack of insurance, and finally, just a quick word on outcomes. As Robin noted, we do terribly on almost every way you measure population health. The last time I checked the numbers, American males were 31st in life expectancy at birth, females 29th, behind Singapore, Croatia, Costa Rica, and neck with Belize and the Sultancy of Brunei. Now, you don't trust the numbers from the Sultancy of Brunei, either do I. They're probably a little dirty, but it's clear, the numbers, it's clear that we're falling behind countries like Croatia. Among rich countries, as you said, almost every way you measure population health, we're last, or very close to last. And it's not just the totals. If you do your commute just right coming into Washington, you can pass through neighborhoods that vary in 30 years in life expectancy at birth. That is to say, people in adjacent counties whose life prospects, health life prospects, vary as much as first world to deep into the third world. We're expensive, we have bad coverage, and we have terrible outcomes. Solution. My solution is Medicare for all. Take the program we know and expand it. We've got experience with it, it's popular, it'll address our problems. I put this forward. You don't study healthcare very long, and you don't work on healthcare issues without developing a heck of a sense of humility. If you know someone who needs more humility, put them to work on healthcare. Many of you know this. So I present Medicare for all in a kind of the humble sense of knowing it's not going to pass next year. Nevertheless, it directly and I think effectively would meet all the challenges I've just noted. There's lots of ways of doing a Medicare for all, expanding Medicare to cover all people. I've developed up my plan. If anybody is interested, send me an email, james_Morone@brown.edu, and I'll send you my 15-page Medicare for all plan with an accompanying article that exhorts you to support it. What I do is I get the last 8 Medicare administrators, get them to work on a committee, get them to work on fixing the program, on thinking about what you'd have to do to expand the program, and then send it to Congress. I'd fund it with it's going to cost, estimates vary. Bill Bradley insists he thinks we can do it for $250 billion. I think that's low. I think it'd probably be more like $400 billion, although you'd be shifting lots of funds that are now spent elsewhere into the healthcare system. And I'd fund it with a VAT tax, with a tax credit for low-income people. In fact, if I were czar of the world, I would do a VAT tax for healthcare and education, but that's a whole other lecture for another time. And if you're a single-payer advocate, you always have to permit topping out. Don't try to go the Canadian route. Americans will insist on their business class frequent flyer miles, and so you'll have private Medigap insurance. Why it works. The logic behind, there's lots of ways to do a single payer, but there's a basic logic that makes it work. And the basic logic is this: the irresistible force. We want more health care. We got an aging population. Look what this technology can do. The irresistible force that says more meets the immovable object, taxes. You want more? You got to pay more in taxes. It forces us to make that decision. You can't simply pass the costs on or shift them to another payer. That's why it works. That's why it begins to control healthcare costs. That's why it works in every country. Every time you want to raise healthcare as percentage of GDP, you got to bite the bullet and say, we're going to raise your taxes. It works in the United States, incidentally, in the other place where we have a highly technological system that's single payer and that has to do with lots of people dying unnatural deaths. I'm speaking, of course, about the defense budget. The defense budget is a single payer budget. And note, go back and look at the numbers. Back all the way to World War II, it's never increased as percentage of GDP more than 5 years in a row, not even in the height of the Cold War. Want to increase defense? You got to pay for it by raising taxes, so it's hard to do. Single payer will solve our health care. All the indicators from any country or from the American analogy suggest that single payer is going to grip because you got to raise taxes to pay. It'll cover everyone. Doing a single payer is an essential philosophical statement about what it is to be an American citizen. Or to put it differently, no more cookie jars at the country stores. And I predict that if you do this, you'll watch American outcomes get better. If you look at the numbers in American outcomes, health outcomes, you'll find we do terribly up till age 65. And then all of a sudden it flips. By age 80, Americans are number 1 in life expectancy at birth. 55, the numbers are just as bad as they are for the younger. Hit 70, and they're good. My prediction, can't prove it. Correlation is not causation. There may be other things going on, but the indicators suggest that you pass health insurance for everyone, and our terrible numbers will start to get better. There's a myth, medical nihilism, we call it. Healthcare doesn't have anything to do with people's health. There's no indicator that that's true. It's a very convenient thing to say in a nation that has so much trouble getting health insurance to its people. But look at the numbers over 65 and under 65, and it's hard to support medical nihilism. Before I end, let me make a quick comment on the other proposals. And let me say 3 things. First, there's a myth out there that Americans love incrementalism. And it's true. Lee Hamilton was just saying Congress is an incremental body. Look, this is not going to be solved by incrementalism. 1 out of 8 Americans have no health insurance. We're not going to cover 50 million people, much less rein in health care costs, with elaborate beltway compromises, complications, concessions. Health reform is going to be a big bang if it's going to be changed at all. So if your support, the case against incrementalism, see S-chip and what's going on with that right now. Employer mandates have just one thing for the employer mandates to think about. Made a lot of sense in the post-war era to have employer mandates and to organize our health care around employers. The problem is that first costs are eroding the employer's appetite for this whole business, but in a quicksilver economy, in a global economy with fierce equity markets and contingent workers and people jumping around with jobs, it's very hard to locate benefits in employment. The economic logic is eroding the employer coverage, and to some extent, employer mandates are grasping at yesterday's economy. Market plans. The problem with market plans, now they've never been taken to scale anywhere, and the basic problem with market plans is that our government isn't good enough to run them. I know that sounds like a paradox, but here it is. What you've got is a series of competitors in a dynamic environment, and you're trying to get them to cover everybody and do some good in the world while they're trying to make money. How do you make money? Insure healthy people. Don't insure the kid's right leg. We're trying to get them to use the competitive model in a way that also solves social problems. The problem with that is entrepreneurs in a dynamic environment are likely to always to be one step ahead of the poor regulators who have to try to contain them in a system that gets everybody covered. Ironically, competition systems require very, very nimble regulators. And the great question for competition systems is our government oversight up to it? In conclusion, if you're a single-payer advocate, you take great comfort in Winston Churchill's famous comment, "Count on the Americans to do the right thing after they've exhausted every other possibility." How do you win in healthcare? How do you win in anything in American politics? It's simple. If you look at American history, I moonlight writing books on history. If you look at American history, what you see is the same thing. Great changes come about because a small group of crazy people, of nuts, takes something they believe in, abolition, civil rights, the Republicans taking over Congress in the 1990s, and they push, and they push, and they push, and it seems just impossible, and people laugh at them, and slowly the army gathers, and then the window of opportunity comes, and boom, they're there with their solution. Medicare, Oscar Ewing had this idea in 1951, let's take national health insurance, convert it to Medicare. They had the program in 1951, and they pushed it for 15 years. And finally, last point, and it's free advice for any program that comes down the pike. If you're advising a presidential candidate, note the window of opportunity closes very, very quickly. The great example of this is Lyndon Johnson. Lyndon Johnson passed Medicare in 1965. Now, the usual story says, huge landslide against Barry Goldwater in 1964. Johnson was going to get anything he wanted, but Medicare first in the docket so that it was sure to go through. There's lots of stories about LBJ with Medicare, but LBJ knew it wasn't inevitable. Recently released tapes reveal him telling his staff, every day I lose power. He's move fast, every day I lose influence. Medicare had been holed up in the Ways and Means Committee for 5 years. Finally, they get it through, the tapes. Wilbur Mills and a group of Democrats call LBJ in his office. We got it through, we did it. LBJ is looking at the next thing. He knows the head of the Rules Committee is not such an advocate for Medicare, and he's worried there'll be a backlash before he gets it to rules. Here's what he says. Now remember this. Now remember this, he says on the phone. 9 out of 10 things I get in trouble on is because they, the bills, they lay around. It stinks. It's just like a dead cat on the door. For God's sake, don't let dead cats stand on your porch. Mr. Rayburn, the Speaker of the House, Sam Rayburn, used to say they stunk and they stunk and they stunk. When you get it out of committee, you call that son of a bitch up there on the floor before they can get their letters written. Their letters opposing it. My final word, in the spirit of LBJ, the savvy health advisor goes to her presidential candidate the day after the election and says, hurry up, Mr. President, or Madam President, you're almost out of time. Thank you.
Thank you, James. That was very, very fun. And that was one of the things that I mentioned to these guys. I said, listen, let's try to make this fun. Boy, you're going to be a hard act to follow. I think Paul is going to be a little bit pressed here. One thing I'd like to just say, if we had Medicare for everyone, Medicare was probably the biggest cause of medical inflation ever. I mean, in ophthalmology, I just wasn't quite in ophthalmology yet. It cost about $400 or $500 for a cataract extraction. Medicare came in 65. By the time I was out and doing cataracts, had gone up to about 2,000 to 3,000, just because of the fact that for LBJ to get that through, he had to kowtow to the AMA, and one of the things was how prices were. And I think that if we went to a Medicare, they'd certainly have to deal with that problem. One of the things that if we all had Medicare and a single payer plan that would be very good is that we would change what I was alluding to when I gave my little piece about procedures. We overpay procedures. We underpay cognitive services. And that is what general practitioners or family practitioners really provide. They can't bill anything because they don't do anything. But actually they do. In fact, in the 90s, we all thought that it was the general practitioner who was going to save American medicine. But the trouble is nobody paid him. And how do you keep a practice going if you don't get paid? In other words, being the kind of the ombudsman to shelter or shepherd the people through our heavily specialized system, they didn't get any payment for that. Well, now I'm going to turn over to Paul Seltman, who is going to talk about some of the things, and I hope that he says some things that might temper James's enthusiasm.
Yeah.
So, several weeks ago, I received an invitation in the mail to a dinner fundraiser. This probably doesn't surprise a lot of you in this room. I'm a lobbyist, so you probably figure Paul probably gets lots of these invitations to fundraisers. Unfortunately, this was a different kind of invitation. And as I discovered from reading it closely, a friend of mine had had a serious stroke over the summer, and she had no health insurance. And now one of her friends was organizing this get-together in the hopes that those of us in this circle of friends would open up not only our hearts, but also our wallets in order to help this family through a very difficult medical and financial challenge. Now, some would argue that this represents a failure of individual responsibility, and others would argue that this represents a failure of our healthcare system or the lack of one. And I would argue that it's both. As the presidential campaign heats up and healthcare ideological warfare is in full swing, everything will seem more black and white, with the two extremes still firmly dug into positions where they've been for quite some time now. And one extreme argues that everyone ought to be on their own to buy health insurance. And while this may sound intriguing, it's unrealistic and has many drawbacks, not the least of which is that it lacks social responsibility, leaving people like my friend without a life jacket. And the other extreme argues that there should be a single national health insurer, a top-down system that is government-run. And while this has some advantages, it is out of step with the American people. It abandons the free market almost entirely and demands little individual responsibility. My hope today is to convince these two extremes to meet somewhere in the middle, to find common solution that would ensure that a medical tragedy like my friend's does not lead to financial ruin. I believe that the best hope for such a solution is an employer and individual mandate hybrid that harnesses healthcare market competition in a socially responsible way. A combination of employer and individual mandates can help us achieve universal coverage in the most expedient and politically practical manner, paying homage to Americans' sense of individualism and fairness by combining individual choice with shared responsibility among individuals, employers, and the government. So going back to the example of my friend, as I said, I believe that there was a failure both of individual responsibility and our patchwork healthcare system. As for the failure of individual responsibility, my friend was self-employed. So had she purchased comprehensive health coverage in the individual non-group market, coverage similar to what I enjoy through my firm, it probably would have been prohibitively expensive. While this may not have been an affordable option for her, my guess is that she could have afforded at least some type of catastrophic health care policy, something that would have helped her in her current situation. So these policies, if one takes a high deductible, for instance, like $2,500 or $3,000 a year, might cost just $150 a month for an individual like my friend, assuming that you're reasonably healthy. But even then, you might have 20% coinsurance associated with this policy, so it is by no means a great fix. And my point is not to say that I favor catastrophic plans, because I do not. But my point is simply to acknowledge the need to promote greater individual responsibility for obtaining health insurance. On the flip side, failure of our healthcare system, or lack thereof it, despite my friend's story, most of the uninsured are not like her. I mean, estimates show that 2/3 of the uninsured have incomes below 200% of the federal poverty level. Now, for those watching who are outside the Beltway, what does that mean? That means that $40,000 of gross income a year for a family of 4, and that translates into about $2,300 in take-home pay. Now, particularly in a city like Washington, D.C., such a family is highly unlikely to have a couple $100s left over at the end of the month for even a bare-bones catastrophic policy. So given this dual failure that I've described, failure of our system to help people access coverage and failure of individuals to take responsibility, I'm very much in favor of an employer-individual mandate hybrid that has been developed recently inside the Beltway and across the country. And while the devil may be in the details, many of the different versions of this model being presented show tremendous promise, ranging from states as different as Mitt Romney's Massachusetts to Arnold Schwarzenegger's California. Senator Clinton now has a health plan based on this model, and even the Heritage Foundation developed the concept of a health insurance exchange, which is really at the root of these hybrid models. So there appears to be movement in the direction of consensus. And what is even more amazing is that Republicans now seem to be moving towards center-left on the healthcare question. A poll, in fact, recently of California Republicans showed that 19% of them favor the single-payer model that Jim just described, and 37% want a shared responsibility model like I'm advocating for today. Only 29% are looking for the free market to solve problems, as Michael Cannon will describe when he's up here next. I firmly believe that these employer-individual mandate hybrids are the most politically viable. And political viability is a very important feature, because if we don't have that, then 47 million Americans are going to continue to be uninsured, and that number is going to keep climbing. The hybrids that I'm describing share, generally speaking, the following types of features. They require employers to pay a portion of employee premiums or pay a fee into a fund that will help pay for insurance for the uninsured. And for example, in California, they're looking at a 4% payroll for employers. Also, these models require individuals to get health insurance and pay a portion of premiums themselves, usually with enforcement mechanisms that also may include penalties for failure to comply. And those, for instance, might be set at a percentage of income. In Massachusetts, they're looking at even requiring people at the poverty level to put out 1.8% of their income in premiums with help from the government. Provide government subsidies to help individuals who cannot afford to purchase insurance, as I just mentioned, possibly up to 300% of the federal poverty level, as well as to give assistance to low-wage employers and startup companies who might not be able to afford health care for their employees out of the box. Also, there'd be new requirements for insurers. And Jim already eloquently spoke about the problems that a lot of insurers can create for people. We would require insurers to offer policies to all comers, known as guaranteed issue, and possible additional requirements. California, for instance, is now telling insurers that their administration and marketing expenses would be capped at 15% of the premiums they collect. They need to spend at least 85% of their premiums on actual health care, not marketing and administration. Most importantly, though, these hybrids, they're driven by competition, namely through insurers competing for consumers through a formal marketplace, a sort of health insurance exchange, to use the Heritage Foundation's term. And through such an exchange, different insurers and medical groups would compete for patients, not by seeking out the youngest and healthiest people or by cutting benefits below acceptable standards like we often have in our insurance market now, but rather by coming up with effective ways to manage care and decrease unnecessary and inappropriate care. And through this marketplace, individuals would have a choice of plans, and they'd receive comprehensive, unbiased information from the exchange itself. Individuals also would be given an opportunity to be cost-conscious as they shop around with either their employer's set contribution or the government subsidy that they've been given. And they can seek to purchase a plan for that exact amount, or they can pay for the difference out of their own pockets. Now, not all insured lives would necessarily be pooled. For example, most employees of large employers might be happy to stick with the insurance they have, and that's fine. But these exchanges will be very, very attractive to small business employees and other individuals who might be in the non-group market, groups of people who currently pay far more for their health insurance due to a lack of pooling of risk. Federal employees have enjoyed this kind of a health insurance marketplace for a long time through the Federal Employee Health Benefits Plan, and its success at keeping administrative and premium costs low is hard to ignore. Administrative costs are less than 1% of the aggregate cost of plan premiums in FEHBP, and in 2007, the average premium increase was 1.8%, compared to a much bigger 6% for private employer-sponsored insurance. And in 2008, next year, FEHBP is only expected to have a premium increase of 2.1%, so it's still very, very low. But finally, the cost containment approach in the hybrid models tends to favor a mix of strategies, including increased use of health information technology and widespread adoption of electronic healthcare records, provider pay-for-performance measures and a greater emphasis on primary care, health promotion and disease prevention activities, and chronic disease management programs. The type of competition between health plans generated by this model can succeed in providing people with health insurance choices and even reduce the cost of their premiums. To quote Len Nichols of the New America Foundation, mandates make markets work better. And I agree with that proposition for a number of reasons. First, there are administrative savings achieved when everybody has to buy insurance, since insurers don't have to spend resources figuring out how to legally deny us coverage. Second, an individual mandate also makes community ratings sustainable because individuals would not be permitted to just come and go from the market as they please. Third, guaranteed issue actually creates an incentive for insurers to keep costs down. If premiums keep rising due to plan inefficiencies or high-cost providers who may or may not be worth the high cost that they charge, consumers can walk with their feet and buy a cheaper plan the next year. Unlike now, when if they walk with their feet, there might not be another company out there who's willing to offer them an insurance policy. It's also important to keep employers involved in the healthcare system, as this employer individual mandate model does. A lot of people like to rely on their employers to take care of obtaining health insurance for them. It's a very complicated process, and it's one less thing for them to have to worry about in their very busy lives. And often, people may view their employer as a trusted source of information, maybe even with an HR department that already has vetted a lot of the choices for you. Of course, an exchange can play a similar role to that of an employer's HR department, particularly for employees of small firms or individuals purchasing coverage on their own. And large employers themselves still may want to be involved as a means by which to attract employees. Finally, I believe that the individual responsibility component of this hybrid is also critically important. Americans, somewhat like Europeans, believe that they have a quasi-right to health care, but that somebody else should pay for it. And we often have a hard time making the choice to spend our disposable income on leisure activities versus, say, healthcare premiums. So I would challenge people on this. If people are willing to spend 25 to 35% of their income to put a roof over their heads, is it unreasonable to ask that they pay, depending on their income level, 3, 5, or even 8% of their incomes in premiums for a health care roof over their heads? That said, while Mr. Cannon and I might agree that more individuals should bear more responsibility for their health care, that is probably where our agreement ends. Too much of the market forces-centric approach relies on the assumption that patients can gain access to all the information that they need to make sound decisions about the purchase of health insurance, and that patients are able to fully understand all that information and or have the time and patience to fully understand it. And in reality, that's just not the case. First of all, there's a real lack of transparency to the consumer in our healthcare system. Medical pricing is far from transparent. Insurance policies are ridden with hidden rules and exclusions, and there's serious complexity in trying to compare policies, particularly if you're not a healthcare expert, and quite frankly, even if you are. But even if we let's say we can increase the transparency of information in our system, only usable information can create true gains in consumer knowledge and thus have a possible effect on the market. And Paul Ginsberg wrote an excellent piece on this in a recent edition of Health Affairs. And as he correctly points out, medical care is more complex than other types of products. And many medical decisions are ones that you have to make at a critical point in time in a very urgent fashion. It's not like purchasing a washer and dryer. The market-based approach also assumes that by having to pay the first $1,000 to $2,500 in care each year, consumers will be vigilant in searching out the best care at the lowest possible price, thereby lowering total health care costs. A major problem with this assumption, however, even if we assume that we forced everybody to buy consumer-driven plans, about 80% of health expenditures are incurred by people with costs exceeding $3,200 a year. So most of these individuals have chronic conditions and thus would expect to exceed their deductibles for the year. So for them, the marginal cost of additional care will be negligible, and after hitting or even knowing that they're going to hit their deductible, the attitude toward health care services is more likely to be, as President Bush likes to say, bring it on. This makes it unlikely that this lion's share chunk of health care spenders would be significantly influenced in their health care choices. Here's another way in which the market-based approach would fail to contain costs. The health savings account products are most attractive to the healthy, who believe that they will be able to squirrel away the funds in their HSA. And this has the effect of making the rest of the health insurance risk pool much sicker and shifting more costs to those with chronic conditions who are unlikely to choose an HSA because they'd expect to exceed their deductibles. Another criticism I have of high deductible plans is that they create incentives for low and middle income families to forego necessary care that can prevent serious and more costly conditions from developing later. Perhaps as important, neither employees nor employers seem to be particularly excited about HSAs as an option. A mere 5% of employees were enrolled in consumer-driven plans in 2007, virtually unchanged from 2006 when we had 4%. And 10% of companies offer them, just a tad more than the 7% in 2006. This just isn't an idea that exactly seems to be catching fire. In the few minutes that I have left, let me say a few words about the single-payer model. The Centers for Medicare and Medicaid Services already controls a significant portion of our healthcare economy, and the full range of healthcare stakeholders are regularly dissatisfied with the agency and its level of control. Patient advocacy organizations, providers, medical device manufacturers, pharmaceutical companies. And I say this as a healthcare lobbyist who is in the trenches every day representing these disenchanted stakeholders. Now, this can only get worse under a single-payer system, and even if it doesn't get worse, the perception will be that it is worse. And here's why. First, the American people are very individualistic and have a long-standing distrust of government. And the federal government can serve as the agent of change for universal health care. But if it were to serve as the single insurer in the country, something akin to mass revolt could result. Second, it's not politically feasible. This would constitute a taxpayer-funded buyout of the private insurance industry and employer-sponsored coverage. This would be too expensive up front, whatever some long-term savings calculations might show. Third, with the government in complete control of the healthcare system, the system will be too susceptible to shifting political winds, as can be the case in some European countries, whereby one political party enacts healthcare reforms, and before one can see whether those reforms are even working, the opposition party is swept into office, out go the old reforms, and in come the new ones. Fourth, CMS consistently struggles to keep up with the pace of technological development and how to best account for it in terms of reimbursement. And Robin mentioned this at the outset. And giving the agency this responsibility and control over all American insured lives only will exacerbate this problem. Fifth, as for cost containment, a single-payer system's global budgets are not politically viable. They're perceived as rationing health care. While they may be capable of slowing cost growth, they don't provide the kinds of incentives for efficiency that a health insurance exchange, a key part of the approach for which I'm advocating, should be able to produce. So in closing, I'd like to invite my colleagues at both the single-payer and free market end zones of healthcare policy to join me at the middle of the field to find common ground. Let's come up with a way to harness healthcare competition in a socially responsible manner so that we can ensure that no one among our friends and family has to endure the kind of financial hardship that my friend and her family are enduring now.
Thank you, Paul. Just a couple of points. One is this rationing comes up all the time, talking about countries like Canada, and people say, well, I would never want that plan because you have to wait so long for elective surgery, my goodness. And they say that it's rationing it, not allowing it. As a writer of medical fiction, thrillers, mysteries, I tell you, sometimes elective surgery is something to avoid. That's just an aside.
Yeah.
But the thing is, we're actually rationing healthcare now. I mean, because we're just rationing it by the fact that it's about whether or not, it's the rich are getting it and the poor aren't getting it. And it's a type of rationing. And we just don't acknowledge it. And it's much more transparent in Canada. I think that the point that Paul makes about the politically more possible is a very, very good point. Should we take nothing, like what happened after the Clinton plan in the early 90s, and just let everything completely go that much more downhill? Or should we accept another plan that that's more possible to be passed, even recognizing the fact that it's going to have some deficiencies? I also just wonder myself is how long is business going to be willing in a global economy to be having to shoulder the problems and the costs of health care? Now we come to the last, letting things happen the way they'll happen. Michael will, I hope, say some things about the first two and give us an insight into his point of view. Mike? Sure.
Thank you very much. It's, I think really what we've got here is a question of who do you want to control the decision of what type of insurance you buy, whether a particular treatment is medically necessary, and when you can stop spending money on healthcare and spending it on other things. Do you want it to be the government? Do you want it to be your employer? Or do you want it to be you? Now, as a libertarian who works in health policy, I have experiences like this all the time where you listen to a couple of speakers go before you and you disagree with so many of the things that they say. And you think not only that, but so many of the things that, so many of the truths that, or so many of the claims that are made in health policy are advanced as truths when really they're not, that you want to go ahead and correct every single one of them. Well, I'm going to try to do a little bit of that at the end, but I went ahead and prepared something to say, so I might as well. At least deliver a little bit of that. And I want to start out by inviting everyone to imagine two hypothetical healthcare systems. In the first system, the government provides equal access to healthcare for everyone. In the second system, the government does nothing. You can call this is libertarian, whatever. The government does nothing to provide healthcare for anyone. It plays no special role in healthcare. It just enforces contracts and punishes wrongdoers. But in this second hypothetical world, healthcare prices fall by 3% per year. Now, I want you to ask yourself, which of those two hypothetical worlds would you consider more equitable? It's very tempting to say the first one, because in that world, within each generation, everyone gets equal access to healthcare. But think about the fact that in the second world, within a generation, healthcare prices would fall by 50%. So compared to the second world, the first one doesn't look so equitable because actually you're making life a lot worse for future generations, because they would have to pay higher healthcare prices. There would be more people who wouldn't be able to afford healthcare. There would be a lot more needy people in need of society assistance from society. And I just want to say, parenthetically, if it seems like that second hypothetical world where healthcare prices fall 3% every year, if it seems like that's pure fantasy, well, I would add that the first world, where the government provides equal access to care to everyone, regardless of wealth, social status, or location, is every bit as fantastic. So I think to achieve, would it even be possible to achieve those sorts of price reductions, to reduce the need for health care, or not the need for health care, but to reduce the incidence of people who need assistance from society in order to get the health care that they and their family need? Well, I think it's an interesting thing when you look at other areas of the economy. You see innovations that actually result in those sorts of price reductions. Look at what's happened over time to things like color televisions, flat screen TVs, air conditioning, microwaves, cell phones, all sorts of computers, all sorts of very products that were very expensive originally, certainly only available to the wealthiest in society. And over time, what have we seen? Well, nowadays, we got a lot of low-income people who are eating microwave popcorn while watching their flat-screen color TV and talking on their cell phone at the same time. These products become more and more affordable, and what makes that happen is market competition. Now, we don't see that in healthcare. And why? Well, I'll make this point when talking to reporters. How much innovation would you expect to see in the information media if every cub reporter had to go to school and get a license from the government before they got a job? Even well-qualified cub reporters who could pinch hit for a senior reporter from time to time would be prohibited from doing so unless they went back to school for another few years and got a license from the government in order to do that. Senior reporters would get to decide how many senior reporters there are in the country, and a question that has a direct effect on their incomes. And every technological innovation had to be approved by the government before it could be brought to market. And technological innovations like using the internet to transmit news or podcasts or other things like that. And finally, if 1/2 of all spending on news came from the government, 1/2 of all ad revenue, if you want to think of it that way, and every special interest in the country, particularly the ones whose incomes depended on how that money was spent, have a say in how that's spent and got to lobby their members of Congress to influence how that's spent. That's essentially the healthcare system that we've got. Every way the government controls these healthcare decisions and the amount of money that we spend on healthcare gives special interests the ability to lobby the government, whether federal or state, to protect themselves from competition in the marketplace. Physicians are able to lobby to protect themselves from competition by nurse practitioners. If you've seen these nurse practitioner clinics that crop up in retail stores, where you go in, you give them your name, they're using electronic medical. You give them your name, they give you a beeper, you can shop, and when they're ready to see you, the beeper goes off. They make an electronic medical record. They use evidence-based medicine. All these sorts of innovations that we're trying to generate in healthcare. If you know anything about these, you might have noticed how physicians responded. They ran to the state legislatures and tried to regulate them out of business. The American Medical Association is terrified that these places might provide low-quality care, even though every study that's been done shows that nurse practitioners provide care that's comparable in quality to physicians and at a lower cost. And the physician lobby does this to protect themselves. Private insurance companies are able to protect themselves from competition from insurance companies in other states because it's illegal for you to go out and buy health insurance in another state. Physicians get to protect themselves from competition from physicians in other states by the licensing laws in each state. And physicians, pharmaceutical companies, and so forth, particularly a lot of the surgeons and other specialists in this country that bill Medicare so heavily, are able to go to the government and protect themselves, not just from competition within the healthcare sector, but from competition for other uses of that money, rather than many of the very useless and often harmful services that those medical professionals provide. To give an example of this, I always talk about the average family of four. Roughly speaking, in this country, the average family of four spends $25,000 on health insurance every year. Well, this year. Next year it'll be more. $25,000. That probably sounds like a lot because you may have heard that the average family policy offered through an employer is only $12,000. Well, actually, the other $14,000 is to buy health insurance for other people, whether senior citizens or the poor through the Medicaid program and others that are provided health care through the government. The average family pays roughly $14,000 in taxes to provide health care for others, and their own health insurance costs $12,000. That's part of their earnings, but their employer gets to control that. They don't get to control that. That's $26,000 is taken out of this family's income, and they don't have any say in this. They don't have. It's very difficult for a consumer to say, no, I want to buy less health insurance for myself and my family and save for our out-of-pocket medical expenses. And certainly, they don't get to control the money that funds their health care and retirement, and they don't get to decide how to provide health care for the needy. And as I mentioned, that's just another way that the healthcare industry is able to protect itself from competition. Now, I spoke about a lot of regulations like licensure and scope of practice laws when it comes to physicians and nurse practitioners and what sorts of tasks they're able to do and not able to do. These are set by state governments. And I also alluded to the Federal Food and Drug Administration, on which we all rely to make sure that all the drugs and medical devices that we use are safe. And there are rationales for these regulations. I think you might be surprised to find how weak those rationales are. And I hope that, I'll mention just briefly that all of the empirical research that's been done by economists on whether these regulations hurt or help have actually found that on balance, they don't do much to help, and oftentimes they leave us worse off with more morbidity and mortality, not less. So why are prices in healthcare so high? Well, I think it's because you get little or no competition among medical professionals and facilities and insurance companies, and the government keeps pumping more and more money into the system. So what would a more free market approach to healthcare look like? Well, I think it's basically breaks down the kind of reforms we'd want to see would break down into two categories. One is reforms that let workers control more of their earnings. Let the worker control more of that $26,000 that I mentioned before. Yes, health insurance is expensive. Yes, it would be hard if we just pushed everyone out into the individual marketplace and said, go buy health insurance on your own. But you know what? If we let them control the $12,000 that their family now controls, they'd be a lot better off. They'd be able to fare much better. The second category of reform, I think, are I usually break this up into the 4 E's of healthcare reform. The first one is earnings, letting people control their earnings. And the next 3 are entry, exchange, and exit. And all that means is let individual consumers and entrepreneurs decide who enters the market, what are the terms of exchange there, and who gets to exit the market. Let the individual consumer decide when to stop spending money on healthcare, rather than say let the government decide that or let the employer decide that. Both options having been proven very unpopular with Americans, given their aversion to either a Canadian single-payer system or the sorts of cost controls that employers tried to impose on their workers through managed care in the 1980s and 1990s. Now, you'll notice that if the libertarian here is right, these sorts of reforms, and I just want to emphasize, would actually, as a libertarian, I want to live in a society where we take care of the neediest among us, where people don't get turned away from a hospital or the emergency room because they're unable to pay. And you'll notice that if the libertarian is right, there's going to be a lot fewer of those cases for society to cope with if we have an actual competitive marketplace rather than the one that we've got. Now, there are a lot of approaches to achieving a freer healthcare market. One of them is health savings accounts that was mentioned by Paul. Another one is something that's been proposed by the Bush administration and has been taken up by Mayor Giuliani in his presidential campaign that would give everyone a standard deduction for when they purchase health insurance. It would make health insurance affordable to a lot more people. Another approach is to let people expose insurance companies to a little competition. Let people buy insurance from out of state. My brother moved into New Jersey with his wife and 2 daughters a couple of years ago. His college roommate lived across the street in Doylestown, across the river in Doylestown, Pennsylvania, with his wife and 2 daughters. Same ages, same family size. And so I did a fun little experiment. I went online and I found out how much, if they were going to purchase insurance for their own families on the individual market, how much would it cost? Well, my brother would have spent $700 per month at least on health insurance in New Jersey for his family. That was the most expensive policy for his buddy in Doylestown, Pennsylvania. They went down from there in Pennsylvania. In New Jersey, they went up from $700 a month. New Jersey is known in health policy circles as health insurance hell. They load all sorts of regulations on their health insurance policies, mostly for the benefit of special interests. That drives up the cost of health insurance. And some have made the comparison to leasing a Lexus and said that it's actually cheaper to do that than buy health insurance in New Jersey. If New Jerseyites had the option of just buying health insurance in Pennsylvania, a lot more New Jersey residents would be able to afford health insurance. And there are lots of reforms that we could talk about to address health insurance for the elderly, health insurance for the poor, this state children's health insurance program that is probably being vetoed as we speak right now. But I'm happy to take questions about any and all of those topics. I thought, though, that I might kick us off by responding to a couple of the things that really got my blood going during the previous presentations. One of them was a point that James made about outcomes. He talked about the World Health Organization study that ranked the U.S. at 37th among nations in terms of health outcomes. What's interesting about that study...
That was Robin.
That was me.
Oh, I'm sorry. I thought you mentioned... Oh, I'm sorry, Robin. Okay, I had it by James's name as well. Well, I'm getting to you.
Yeah. I'm ready.
An interesting aspect of that study is that a lot of those measures had nothing to do with health outcomes. For example, if you look at how the World Health Organization, they have all sorts of categories in which they rank all these nations. One of them was a measure of equity. Now, several of them, I think, were measures of equity, and one of the measures of equity worked like this. If you have two countries that have exactly the same health outcomes, and then one of them, in one of those countries, half of the country gets better health outcomes, and everyone else is the same, that country that just made half of their population better off is ranked lower. They fall in the rankings for having made those improvements in health because it's an unequal distribution of health. Those and others, the Cato Institute is putting together a study on this by an economist out in California. Those and other measures of equity actually penalize countries for making gains in health outcomes. When it comes to health outcomes like life expectancy, I think that's what James mentioned.
Yeah.
And interesting, it's true. We don't have better life expectancy rates in other countries. But when you look at life expectancy data and how those are compiled, they incorporate a lot of things that have nothing to do with the healthcare system. For example, accidents, automobile accidents, homicides. We have higher rates of these things in the United States. And when you control for those things that have nothing to do with the healthcare system, just those two items, our life expectancy actually exceeds any other OECD nations. So I think that life expectancy is still a lousy measure of the performance of our healthcare system. But if you accept that it is, then you must say, gosh, the U.S. system is marvelous compared to other systems internationally. Now, I am no defender of our current system, as I hope I conveyed in my remarks. I think that our system is a mess, and it spends a lot of money on unnecessary care and even harmful care. So I think that when you do compare nations against one another, it's very hard to find any benefit that we're getting for all the additional money that we're spending on healthcare. I think we spend 50% more than in Canada or something like that, and it's very hard to find any health outcomes measures that would justify that greater expense. I think that maybe the only two are that we have greater access to treatment for chronic illnesses, and that's just access, that's not even outcomes. And we have higher cancer screening rates, which result in lower cancer mortality to incidence ratios. But that's about it. Yeah. And so I think that there's a lot of improvement to be made. We had it at the Cato Institute. We have an online magazine. It's called Cato Unbound. At my behest, the most recent issue of Cato Unbound featured a debate between an economist named Robin Hanson and three very well-known health economists, David Cutler of Harvard, Alan Garber of Stanford, and Dana Goldman of the Rand Institute, where they debated Professor Hanson's contention that if we just cut medical spending in the U.S. In half, our health outcomes wouldn't be that much worse. They wouldn't be noticeably worse, even if we use blunt tools like a global budget or raising prices, eliminating all the subsidies that the government provides for healthcare. And it was a very controversial and thought-provoking discussion. But the basis for that discussion is it's very hard to find any difference in health outcomes from one nation to another based on the amount of or the differences in the amount of money that we spend on healthcare. Finally, I wanted to respond to something that Paul said. I don't see an individual or an employer mandate as being sort of a middle ground between a free market system and a totally government-dominated system. And the reason is, the key is really what I said before about that $12,000 that your employer spends on health insurance being part of your earnings. Economists agree that if employers were not providing you health insurance, they would have to give you that money in cash because the labor market would push them to do that. So when you look at an employer mandate, let's say, in that light, essentially what you're saying is that not that employers have to provide health insurance. It's more accurate to say that employers have to take a portion of the workers' wages and spend that on health insurance, which in effect just gives the government control over the workers' earnings in another way. What's the difference between that and a tax, saying the government is going to take that money and then spend it on workers' earnings? Either way, you're taking the money away from the worker. You're not letting them choose how that money is being spent. The people who are going to choose how that money is spent is the employers to some extent. But the government has to define exactly what health insurance means. And so what happens then is every special interest with a financial interest in that definition runs to the government and says, I want my services covered. I want this covered. And the healthcare industry in general has an incentive to force people to buy more and more health insurance. And that's exactly what we've seen in Massachusetts after they implemented, albeit an individual health insurance mandate requiring all residents to buy health insurance. The first thing that the Massachusetts regulators did was they required everyone to buy pharmaceutical coverage, which increased people's premiums there. And then they required people to buy health insurance with deductibles of no more than $2,000. Well, a lot of people in Massachusetts had health insurance that was already, that had higher deductibles than that. They were satisfied with that coverage. And then, so all that regulation did was increase their premiums and leave them with, make it harder for them to afford coverage that was less desirable than what they had before. So I think that an employer mandate puts the government in the driver's seat every bit as much as a single-payer system does. I have lots more. I think there's lots more to be said about all these things, but I'm going to stop right there and look forward to your questions. Thanks.
Thank you, Michael. We're almost out of time, but let's take a couple of questions and see if we can get these guys to argue a little bit more with each other. And anybody have a question they'd like to?
Because if you don't, we're going to get going again. The warning.
Hi, I'm Ross Johnson with the Wilson Center and the Hoover Institution. How could one enforce the mandate or the requirement that and if it's not employer, that an individual buy health insurance? We say we do that with automobile insurance, but we really don't. So how could that be addressed?
Well, I think in the plans that are being designed, there are financial penalties, and they're collected from people through the tax process. So it would come through when it's tax time. Also, I mean, I don't know, just as from what I've never really. I mean, I'm a lawyer by training, but like a lot of us here in D.C., I only play a lawyer on TV. But from what I remember when I was in law school and had some traditional lawyering jobs in the summers, and I saw some cases like this play out in court with people who hadn't had car insurance when the law mandated it. The judges came down very, very hard on people financially when they had not purchased car insurance and then actually injured somebody in an accident. So I think that that's something that might also play out in civil penalties.
But that's a penalty that's already available. People are already responsible for their health care bills. They can get dragged into court, and judges can be very harsh on them. I think the enforcement mechanism is a very important issue when it comes to the individual mandate or an employer mandate. There are pretty stiff penalties for driving without auto insurance in almost all states. And yet, in states like California, you have 25% of motorists that don't have insurance, which is, it's roughly the same as the number or the percentage of people who don't have health insurance, even absent a mandate. So it makes you wonder just how much compliance are we going to get with this mandate. Likewise, we have one state, well, now two states in the union with an employer mandate. The first was Hawaii, and the second now is Massachusetts. And in Hawaii, there's been a lot of avoidance of this. There's been avoidance in the sense of, I think the threshold for employers is if you have more than 10 employees in Hawaii, then you have to offer health insurance. So, firms just don't expand beyond 10 employees. Or they hire part-time workers so they don't have to buy insurance for them. There are all sorts of these, what economists call margins of substitution, that allow people to avoid the mandate. And then some evade the mandate. Some just flout the mandate.
A mandate won't work unless you fix the insurance system. Right now, half of all bankruptcies, this is your point, half of all bankruptcies come from healthcare tragedies. In the current employment system, in the current insurance market, simply telling people go out and get health insurance doesn't work yet. You've got to fix the insurance market, which all three of us want to do.
There's a healthy debate in the Journal of Health Economics about whether half of all bankruptcies are a result of healthcare expenses. You could say the same about all sorts of other debts that people have, because all these things contribute.
The point remains, though, that we're not going to an individual mandate won't work in the current insurance markets.
No, I mean, subsidies have to be provided to people to help them, because it's clear that probably as many as 2/3 of the people who are uninsured just don't have the funds to do it and are not like my friend was.
Subsidies do have to be provided, but I would argue that when you try to force coercive subsidies through the insurance markets, that causes people to react in ways that make the market unravel, that drive up health insurance premiums for everyone, that encourage people to consume more care than they otherwise would, and a lot of unnecessary and harmful care. I think that a better way to help those people who need subsidies is to deregulate the insurance market, let it cover as many people as it can, because it will cover more people than it's covering now, and then provide direct subsidies to people who are left out of the market and need help. I don't think you want to make the health insurance market collapse by trying to force subsidies through it.
Here, right here in the front.
Thank you. I have some comments, and then I have a question actually for James Morone. I represent actually the Gray Panthers, and we're obviously very active proponents of single payer and care very much about social and economic justice. First of all, we believe, and I believe, that health care is a right, not a privilege, and that's where the argument starts. And I also believe that if the United States wants to remain competitive and have an effective workforce and healthy citizens, that it is to their benefit to have every one of those citizens insured. Using the political viability argument, which I have in the past, really takes away, I think, our responsibility and energy towards working for a system that works for all people. So while we're out busy talking about band-aiding, we could be actually, I think, doing the work for a system that works for all people, and use our energy towards that. We've been band-aiding for years. So the middle approach just reminds me of what we've been doing, and it just hasn't been working. To leave the marketplace, which cares only about profit, that's what they care about. That's in matters of healthcare, to us, just makes absolutely no sense. So saying that, how do you get past the influence of the AMA, the insurance companies, and the pharmaceutical companies, which really nobody talked about today, to actually enact a healthcare plan that works for all people?
Yeah, I mean, that's the largest problem with single payer. And what you have to do is be a historian. Look at the great changes in American history and think about how many things have come down the pike. Let me back up for a second. Look, if the Democrats win, what's up is this plan over here, is Paul's plan. We're politically infeasible, guilty as charged. And anybody who's done healthcare for any length of time is not going to insist on we've been humbled. No single payer advocate who's got any sense is going to say, no, I want the whole loaf, not Paul's 4 slices. We'll take the 4 slices and go from there. So this is, if the Democrats win, this is what's up, and I don't think you're going to see the usual circular firing squad among advocates of health reform. So your turn. Having said that, I go back to the great change. It would be equivalent to the great changes in American political history. They do come. There are moments when we call it a punctuated equilibrium, when suddenly there's a dramatic opportunity. 9/11. 9/11 was an opportunity like that. A president could have taken 9/11 and rather than use it the way it was used, could say, we're all in this together. Let's think what that means. It would have been very hard to come forward against an articulate president who had said, this is what this means. That would have been that moment. And that's how it happens in American history. Watch for the next one.
I'd like to comment on a couple of things. Regarding the AMA, I'm sorry that you apparently slept through my presentation.
No.
Because I spoke a lot about
Just
the interest
disagreement,
groups.
polite disagreements,
And the
okay.
only way to get the AMA, the only way to get the medicine out of politics is to get was to cut off the mics, apparently. Is the only way to get medicine out of politics is to get the government out of medicine. As long as the government's involved in healthcare, paying for half of the healthcare we have in this country, regulating the rest of it to death, then I think you're going to have lobbyists who are going to want to influence it. And unless you shut off their right to their First Amendment rights, there's no way to stop that. Second, you mentioned profit. I think that in a system where the consumer controls the dollars, profit's a good thing, because that tells you that these people are providing value, and it serves as a signal to others, hey, jump in and provide more value here, and those profits end up shrinking over time. And as for a right to health care, I was at a fascinating dinner a few months ago where a very educated woman who is both a doctor and a lawyer started off by saying what we need in this country is to establish a right to health care just like we have in education. And then all these healthcare bigwigs at the table for the next hour and a half were talking about all sorts of different things. And this woman took the floor again to say that, to complain that her organization's outreach efforts, the pamphlets that they put out to the public, have to be written at an 8th grade level, because just in order to communicate with her target audience. And I said, wait a second, how do you reconcile those two statements that you made? We have a right to education, and yet people are only reading at an 8th grade level. Do you think that maybe if we establish a right to medicine, a right to health care, we're going to have the same sort of problems? And if you look at countries like Canada and other nations, you find they're great at 8th grade level medicine, but they're not good at graduate level medicine. And if there's one thing that can be said about the U.S. healthcare system, and I'm not saying this redeems it, it's that we do a very good job at medical innovation that improves quality, that gets you that graduate level medicine.
Okay,
For lots of people, not for everybody,
Let me jump in with just two.
Certainly everyone on Medicare.
Two choices on whether you're gonna go for Michael's take, and let me just put them as questions so that we can. There is an economist's dream that says products will be more. What makes products more affordable? There's this dream that here's your choice. Do you believe that government is the cause? Does it make sense to you that government is the cause of all the ills of the healthcare system? If you do, you buy his notion. Or you might believe that healthcare is different. It's not like flat screen TVs, and you make the choice. That's the choice before us. There is no national health example that's sustained over time that reflects the market model. A second choice. Regulation is a middle ground. The reason we have the system we have with lobbyists all over, and I don't want to say negative things about all you lobbyists in the room, but the reason we have a heavily lobbied system is that the government is too weak. It's the way Madison designed the system, right? The way Woodrow Wilson had it. It's too weak to act strongly and firmly, and yet it's too weak to resist lobbyists, and yet problems keep being pushed to the government. It is the design of our government that makes that happen. That's why we only occasionally get great changes. And the dream that we can get away from that is a dream of getting away from the Madisonian political system.
I'm going to have to intervene here. This is